So, so in this lecture, we will discuss how meta-analyses are being performed in sleep medicine on a very introductory way. I understand that this lecture will be available in YouTube, so we will go through some basic aspects of meta-analysis, and then we will progress slowly into how meta-analyses are being published nowadays. So to begin with, let's consider in a nutshell what meta-analyses are. And here I will be mentioning meta-analysis many times, but please understand I am referring to systematic review on the broader sense, understanding that a meta-analysis is the last step on most systematic reviews, not all of them for sure. And obviously there are alternative systematic reviews like scoping reviews, which I like very much, like umbrella reviews, like mapping reviews, and there are broad sort of types of systematic reviews being published nowadays with some peculiarities for each of them. But to start with, what is the main feature of a systematic review? Basically, we try to synthesize the literature on a certain field. This is the systematic review, and we combine results in a statistical way to reach a final effect size or a final result when we combine everything on a single statistics. This second step is the meta-analysis. So basically, the systematic review, it brings the consistent results that we can find in the literature, usually with a high evidence level. Although these might be disputable, we don't necessarily consider meta-analysis as the highest level of evidence anymore. And the 3 steps, if we can summarize into 3 steps the whole process of a systematic review and a meta-analysis, and this is very simplified, but if we can choose 3 steps, the first step is to screen the literature. We have to screen deeply the literature to assure that we are able to find every possible study, every possible randomized control trial, if we're sticking to this type of methodological design, every possible preprint article for things that haven't been published yet. Because if we are not able to find everything that is available, and eventually things that are not even available already, we might step our feet into some kind of biases like publication bias. So meta-analysis has to be the most comprehensive as possible when we try to screen the literature. Once we screen the literature, so when we go to the databases, anyone who have had the experience to enter PubMed knows that every possible search strategy will bring some non-intended search records within it. So we have to filter those search records to keep with those that are relevant to our research question. So basically every search strategy, they have to be sensible, but they end up being they have a very limited specificity. So the filtering process, which we can call an eligibility process, or the application of inclusion and exclusion criteria, has the intention to filter those studies that are within our research question, within our research goals, and so on. And only once we have the final set of articles that we have to analyze, we will perform the so-called meta-analysis. And the name is kind of self-explanatory. So the prefix meta refers to something applying to itself. So a meta-analysis is basically an analysis upon analysis of previous articles. So please understand, although I will be using meta-analysis as almost a synonym of systematic review, this is an error on my side, because a meta-analysis is simply the last step on a systematic review, the statistical step that summarizes the effects of previous studies. So on a very traditional perspective in epidemiology and evidence-based medicine, we have this evidence pyramid. And you can see that the systematic reviews on this traditional perspective is on the top of the pyramid. You might understand that as higher as we go in this pyramid, higher is the evidence level we generate. There are some evidence pyramids that even have a lower ground here of preclinical studies. And the idea is that since systematic reviews can summarize everything that is located above it, below it, it obviously produces more evidence. That was the traditional framework. But people were trying to recontextualize it, because the fact is that systematic review is not always the only, neither the best way to synthesize evidence. So the first step to revise the pyramid was to chop out the systematic reviews from the pyramid. It is not necessarily a way of generate evidence, but actually a way of understanding the evidence that is available. So if we can quote the now traditional and classic article by Murad, you can say that systematic review and meta-analysis are a lens through which evidence is viewed and applied to patient care. So it analyzes the evidence that came before. And this brings one important reflection. We cannot say that a systematic review brings more evidence than a randomized controlled trial, because that's not only a matter of publishing results, but also understanding the relevance, the quality, and the reliability that each piece of paper brings. So an article is just a piece of paper. And once something is published, it's not necessarily true, it's not necessarily applicable to all cases, and that has to be analyzed very carefully. Let's consider the case of a systematic review with a very poor methodological quality that cannot be taken from a perspective of a decision maker as a ground truth. A poor quality systematic review brings no evidence. Actually, it harms the process of synthesizing evidence. So one very well-performed cohort might bring more evidence than a poorly performed systematic review. So let's bring into the discussion not only the fact that systematic reviews brings evidence, but that this evidence has to be understood from the perspective of a methodological quality. That said, let's bring this discussion now into sleep medicine. And let's try to understand why we are publishing systematic reviews and meta-analysis in our field. So there are three main reasons for that. These are reasons that every sleep researcher that publishes, that performs systematic reviews, they understand it implicitly. So the first thing, and this applies to any field actually, we are no longer able to follow the literature. So if there is one piece of paper, one academic article that can summarize other hundreds of articles, that is very, very helpful. So since we cannot read every paper that is published, and you know that there are hundreds of new papers in every single field coming to PubMed every day, I will not be able to track that. And now we'll rely on systematic reviews, just as I will rely on narrative reviews if I am like beginning studying a new field on the beginning of my career. But as we progress into our careers, we move naturally into systematic review and meta-analysis. A second reason why we publish systematic review is that any single study is limited. You might take 5 years of your lifetime to prepare, perform, and publish a randomized controlled trial. But we have to embrace the idea that your randomized controlled trial is not the ground truth, because there are some peculiarities, there are specificities that might turn your randomized controlled trial into something with a limited external validity. We have to compare your randomized controlled trial with other randomized controlled trials. And let's say that the truth doesn't come from your trial, but from the consistency that derives from the relevant results from similar randomized controlled trials published with different populations in different countries, with different biases and so on. So a meta-analysis is the best way to congregate together all these studies that might be similar. And the third process is to assist on the process of taking decisions. So let's say I am a healthcare manager on a small city, or I have a budget to implement a new sleep-related policy in my country, in my city, and so on, I may rely. I guess we have some background noise from somewhere with a very nice song, actually. Well, so the third reason why we may publish systematic reviews is to assist on the process of taking decisions. So if I am a manager and I have budget to implement new sleep-related interventions into my city, I won't have the time, and not necessarily I won't have the knowledge to understand single papers. So I might rely on a meta-analysis saying, hey, I've analyzed these hundred of articles and I can say this is effective for this or that related conditions. So we assume the idea that a good systematic review will provide robust conclusions. Although this is not necessarily true, if we bring back again the idea of understanding it from the perspective of quality, methodological quality. So these were the steps and the considerations I took to start my career on systematic reviews on sleep medicine. I'll share a little bit of my first steps into it so we can progress of how I started it on my field, and then how other researchers also did the same. So my first steps into systematic reviews shall be understood by the fact that I was a preclinical sleep researcher by the beginning of my career. I used to work with rodent models of sleep deprivation. And by the beginning of my PhD studies, I was intending to evaluate the effects of sleep deprivation into anxiety models in rodents, in rats. And so I was evaluating the tools we have available to either sleep deprive a rat or to evaluate anxiety in these animals. That was very much rooted on the fact that in human beings, sleep deprivation leads to increased state anxiety. There were several studies in human beings saying something like that human beings, when they are sleep deprived or sleep restricted or sleep fragmented, they are always in a situation of increased anxiety and increased impulsivity. And to confirm that, I performed my very first systematic review, which was, in that case, in human beings. That was not a preclinical systematic review, but just to reassure that my background knowledge of sleep deprivation leading to anxiety was true. And then I went into my research question. So I realized that although in human beings, the effects of sleep deprivation to anxiety were very much consistent, in preclinical research, they were not. There were a handful of studies saying that rodents, preclinical animals, when they are sleep deprived, they enter into a condition of anxiogenesis. So they increase their anxiety levels. While there were some others in which the sleep deprived animals displayed a condition of anxiolysis. So they decrease the anxiety level. And look how interesting is that. This is one article from my master's. And this is one article from my master advisor. So even within our research group, there were no consistency into it. So once I realized there was no consistency and that the translational potential was reduced, what did I thought? Just like most early PhD students that intend to change the world based on very superficial ideas, what I thought that I could develop a new primary study that would solve all the discrepancies and the inconsistencies of the 30 studies that came before me. But actually, never one single study will change the world, as I mentioned before. And considering that there were 30 studies before me and they were not able to solve any inconsistency, I would just bring one new piece of paper into the noise that was already in place. My new study will not solve anything. It would increase the mess that we had at the moment. So then I realized that instead of a new study, I should go into theory and reassess in the most comprehensive way what was there available to try to understand the patterns and the reasons why the results in rodents were different from the results in human beings. So I went into systematic review and meta-analysis of preclinical data. This is most likely one of the first preclinical systematic reviews in sleep medicine. There were, at that moment, 2016, two researchers dealing with preclinical systematic reviews. That was me here in Brazil, and Kathleen Lennars in the Netherlands, in the Radboud University in Nijmegen. And we had some nice work together at that time. And this systematic review was a large one. So we had 50 articles with 81 experiments intending to evaluate the effect of sleep deprivation in rodent models. Here is the forest plot. We cannot understand that. You will not be able to read every individual article. So I bring this alternative to the forest plot, this kind of graph here. This is one type of graph that is very much used by a systematic review group in Scotland named Camerades. Basically here, the shaded gray horizontal bar in the background is the overall effect size of the whole meta-analysis. And every bar here is one stratified meta-analysis. So I can compare the overall effect with the effects in rats, in mice, in any species, in total sleep deprivation, in REM sleep deprivation, and so on. But the overall result here, and the most important thing here, is that overall rodents, when they are sleep deprived, they display a situation of anxiolysis, which is opposite to what is seen in human beings. So you can see that in animals, when they are sleep deprived, they display anxiolysis. Human beings display anxiogenesis. The same for total sleep deprivation and REM sleep deprivation. So basically, I could show by means of systematic review and meta-analysis of preclinical data that our rodent models of either sleep deprivation or anxiety have no translational validity. And basically, this was the moment in my career that I stopped working with preclinical animals, because slowly and gradually I start questioning the validity of these models, because my meta-analysis were showing that not only for anxiety, but also for other behaviors, for depressive behavior, for maternal behavior, and so on. And then I moved slowly from preclinical systematic reviews into the clinical ones, which I've been doing nowadays. So basically, this whole history might be useful for other researchers to understand systematic reviews as a tool to approach a new research field for which you were facing inconsistencies, methodological challenges, and so on. Understand that systematic review is a methodological tool in the process of synthesis of evidence. So that said, I started at that moment working with meta-analysis in sleep medicine, but it seems that I was not the only one. And actually, many people started performing their systematic reviews, which seems very interesting at the first place. So I guess that was around 2021. I published this scope review, and that was more like a mapping review, actually, intending to map the publication of meta-analysis in sleep medicine. So you can meta-research very deeply here. There is a mapping review, mapping meta-analysis in sleep medicine. And why was that? I was seeing that the publication of meta-analysis was growing in our field, but I was not sure about the quality of it. So you can see that if we see the publication rates of meta-analysis, in the first graph here, we can see the publication growth in total numbers, regardless of the type of article, of the methodological design. And here you can see the publication rates of meta-analysis. So you can see an almost exponential curve here. If we take the whole period of 45 into 2019, more or less 0.44% of the whole publication output in our field in sleep medicine were meta-analysis. But then if we take the last year in analysis here, more than 1%, more than 1 in each 100 articles were meta-analysis. So that was clearly a trend of people publishing more and more meta-analysis. And then I start questioning myself, although we are increasing the publication output of meta-analysis, is that sufficient for the standpoint of evidence synthesis? My strategy to solve this simple question, is that sufficient, was to compare sleep medicine to its parent fields, from the fields from which sleep medicine have born, basically cardiology, neurology, psychiatry, pulmonology, ORL, and pediatrics. So if we compare all these fields all together, more or less 1.62% of the whole publication output were meta-analysis in 2019. And the first year in which the number of meta-analysis surpassed 1% of this among the publication output in all these fields, it was in 2015. Sleep medicine was delayed in comparison to the other ones. So it was 1.10% in 2019, meta-analysis among the whole publication output, and we surpassed 1% only in the very year in which these analyses were performed. So what were the conclusions of this study here? First, that meta-analysis in medicine are less common than other fields, and so there is potential to grow. And that sleep researchers, and this should be read carefully, because I don't fully trust in that anymore. So sleep researchers should be encouraged to perform and publish meta-analysis. And but as long as the analyses are reasonable and feasible from methodological, statistical, and practical standpoints. But I was truly encouraging people to perform their systematic reviews, and that was it. But then a very important fact in human history took place on this very year, in 2019 to 2020, which was the pandemic. And the pandemic kind of changed my mind on blindly stimulating people to perform their systematic reviews. The fact was that
or leading the team or this or
so during the pandemic, we entered a very clear infodemic condition, infodemic being an epidemic of information. So the number of studies increased in basically every possible area, and the same was observed in sleep research. So you can see that this is the publication output in our field in sleep with a very simple sleep search in Scopus. And you can see that it was more or less stable, and in the last years, it increased more. But in 2021, almost 20% of the whole publication output was related to COVID-19. So you can see that something that was in our lives for 1 year and a half, more or less, in that moment, took 20% of the publication output, and also increased the publication, the percentual growth rate of our field. So there is no question about it. COVID-19 changed the landscape of publication in sleep medicine. Why was that? Well, there are two reasons why this infodemic condition appeared, and why we as sleep researchers started publishing COVID-19 related studies, and some of them being meta-analysis. There are the good reason and the not so good reason. The good reason is that, well, we have a pandemic, we have a medical and epidemiological emergency, so we have to deal with it. We have to generate evidence to deal with it. And you might remember that by the beginning of the pandemic, we were questioning whether OSA could be a risk factor for severe COVID, whether CPAP machines were safe for people with COVID, because they might spray viruses around and so on. So we truly had to generate evidence to understand if that were true or not. But the not so good reason was basically an effect of this publish or perish paradigm. We had to publish, and many people saw in the COVID pandemic a good opportunity to start publishing debatable papers in a very easy way. And you can see that during the first 2 years of the pandemic, 2020 and 21, the amount of highly speculative research was like evident. I bring here on this chart two examples, which for me, and this is a personal opinion, but for me, these were the two kind of research that were more suggested, more related to this speculative research. So research about sleep apnea, grounded on the fact that people were considering sleep apnea as a risk factor for severe COVID. You can see that more or less half of the research on sleep apnea and COVID were original articles, but a huge amount of them were theoretical articles, and some of them systematic reviews that were being published, even knowing that we have very few original data to analyze. And many of them were letters to the editors. The number of letters to the editors being published in the pandemic, it was really like increasing considerably. And the same for melatonin. Melatonin was more speculative, even more speculative than sleep apnea, because a number of articles suggesting melatonin as a complementary treatment for severe COVID or as a prevention for COVID, based on no evidence. The evidence were generated slowly. Now we have something, but at that moment was purely speculative. So basically, what was explaining that was the fact that people were away from their research places. They had to publish regardless of that. So what can you do at home, away from your hospital, your laboratory, your clinic? What can you publish? You can publish easily a systematic review, because everything you need to publish a systematic review is a computer and some colleagues, not necessarily in the same place as you. They can be at their homes as well. So by the middle of the pandemic, by the end of 2022, we had more or less one meta-analysis on the relationship between sleep and COVID. That's not meta-analysis in the general sense. That's only sleep and COVID, one meta-analysis in every 6 days. So I started my talk saying we cannot cope with the amount of original data being published. And the fact is that we cannot cope with the amount of meta-analysis being published anymore. So basically, we have entered a condition that John Ioannidis, a very famous epidemiologist from Stanford, we enter in sleep medicine a condition of mass production of systematic reviews, in which many of them, and I might intend to say most of them, might be either misleading, redundant, unnecessary, or flawed. And I would say the biggest problem among them all are the redundant meta-analysis. Let's say some of you guys listening to this talk now, you might have an idea of a very nice systematic review, and you start working into it, and you register your systematic review into Prospero, or if this is a scoping review, you register at the Open Science Framework, and you perform just by the book, as it is supposed to be, and you publish it. And the next month there will be 2 or 3 more systematic reviews on the very same field. Eventually, they were not pre-registered as they should, and so on. And the idea that the kind of the ethics behind systematic reviews, we don't like redundant efforts. So if Masoud has an idea of performing a systematic review, he will register it. If I want to perform a new systematic review, I should look out for protocols or for registries in databases of protocols. And if I see that Masoud has the idea to perform some systematic review similar to mine, I want to perform something similar. I want do some redundant work. I might contact Masoud and say, hey, I want to work with you. I think your approach should be different here and there. But that's a problem. And the problem comes from the fact that nowadays we have meta-analysis on the same field, but with conflicting results and conflicting conclusions. This is a big problem. So said, meta-analyses are now being published, and we come into are now being published on huge numbers. So now my concern is on the methodological quality of these systematic reviews and meta-analysis, because whenever we had this intention to balance quantity and quality, the quantity will always speak louder. You might have your very best systematic review being published. If there is one good systematic review among 10 not so good systematic reviews, we cannot assure the readers will be able to set apart them. So quantity always speaks louder than quality for most of the readers. And this is advancing some of my discussions on the next slides. This is why I truly believe that investing on systematic review literacy is something important for people to be able to understand what a systematic review is beyond the forest plot. So these are some studies demonstrating how the average quality of systematic reviews is poor. And please understand here that I am not criticizing any particular systematic review, but the overall framework. There are fantastic systematic reviews being published, but as I mentioned before, they might get diluted among some not so good systematic reviews. This first paper here on your left-hand side, that was published by Sheng Xu, a very nice researcher with a very good perspective on how good systematic reviews are published. He basically took a sample of systematic reviews and evaluated the average quality using a very reliable source, a very reliable tool named MSTAR2. That's a tool we use to qualify and quantify the quality of systematic reviews. I would say MSTAR, and if you are interested in evaluating quality of systematic reviews, take a look into this tool. It is a very rigorous tool. It's very hard to be considered a high-quality systematic review by this tool, but you can easily be a moderate quality systematic review. But the fact is that, as the author, now I quote the authors, they say that the methodological quality for current systematic review in meta-analysis was poor. And that is in comparison with a paper I did with some colleagues in Brazil, in which we evaluated specifically sleep-related COVID-19 meta-analysis. Most of them were of critically low quality. So again, we have to invest on systematic review literacy. So I won't take any decision made based on a bad systematic review. So I have to find the good ones. And the same is valid for more niche fields. So we have now appraisal of methodological quality for systematic reviews on insomnia, on sleep apnea. Here there is a case of mandibular advancement devices as well, showing that we might be taking decisions and clinical decisions based on debatable results coming from systematic reviews. Another result from Xu demonstrate that there are some very common mistakes on systematic reviews related to data extraction and to data analysis that, if done properly, the result of some systematic reviews could be changed, either changing on the effect size, or even changing the effect direction of some results. So this is a very nice paper, very hard to read because it's very technical. This is for those who really like meta research. But this is very much concerning. You can see that 6% of the sample he has evaluated could have their effect changed from the opposite direction if proper methods were implemented. And in the same direction, I did some analysis of average quality on systematic reviews based on the top-cited meta-analysis. This is an approach that's common for many areas, evaluating the quality of the top-cited meta-analysis, because we might understand that indirectly, the top-cited are the most relevant ones, most relevant in terms of impact into the community, impact on clinical practice, and so on. And again, most of the most cited meta-analysis in sleep medicine are of critically low quality. That might be explained in part by the fact that there are old meta-analyses, and some of them older than the guides we now have to publish meta-analysis. So the PRISMA guidelines, the Cochrane handbook, which is kind of old, but the later versions are more complete and are newer than that, or the Prospero registry and so on. So I took some time here to question the quality of systematic reviews. And you see that I don't believe blindly on systematic reviews, as I don't believe blindly in anything. I don't believe blindly on any paper. I don't believe blindly in any people. I believe on things that I can evaluate, and then I gain trust on it. So can we say systematic reviews are reliable? Sure, we can say, provided that we can distinguish the good systematic review, the bad systematic review, and the ugly systematic reviews. Which are the good ones? Those that are performed with a good background and performed with the proper methods. You might recall one of the most traditional recommendations of systematic reviews, which is you have to have at least 2 people on a systematic review project. One has to be a systematic review specialist. The second has to be someone who has experience on the field being reviewed. And this team, systematic reviewer, and especially on the specific field, make the perfect team. If I have 2 people who knows everything from about systematic reviews, but don't understand about anything about sleep, that will be misleading, that will be bad. If I have 2 very experienced sleep researchers, but they don't know nothing about systematic reviews, they will struggle to implement the proper methods. So the good one are those that we should look for, but there are the bad ones, those that are unreasonable. They are not justified, they are unnecessary, they are misleading, and so on. No, the bad, they are just not necessary. And the ugly are those that might be misleading. So they are flawed. They might lead, if implemented into clinical practice, they might lead into problems to the patients, basically. So answer to this question, are systematic reviews reliable? I do think we should invest in systematic review literacy, and that means that people, readers of systematic reviews and policymakers should be able to understand systematic reviews. And we should not blindly trust on any of them. We have to be able to evaluate the quality. So first we assure the quality, then we understand and implement the results. Journal editors have a very important role here. They should rely on reviewers who are experienced in systematic reviews to revise a systematic review. Otherwise, let's say I am invited to review a paper to a journal about molecular biology of some cancer. I know nothing about it. Will I be able to review that? No, for sure not. And why so? So why are people reviewing systematic reviews without the basic knowledge about it? The truth is that very few people are doing and accepting peer review invitation nowadays. So the idea of peer reviewing doesn't exist anymore. You should understand that a peer review, that's a review performed by a peer of someone who is at least as qualified as I am. But those, let's say Masood, how many invitations Masood receives to review papers every single day? What is the proportion of invitation he accepts? So if a journal or a journal editor invites Masood and Masood doesn't accept it, the journal editor will try the second, the third, the fourth, no one will accept it. But then there will be the early career researcher who will accept it, probably not as qualified as Masood. So there is no good peer review anymore, at least in the bigger journals. This is a real big problem. And you have to remember that publishing, the big publishers we have around, so Elsevier, Springer, BMC, PLOS, they earn a lot. The profitability of these publishers is huge. So why don't we have statisticians hired by the journals and the publishers revising these papers? So, well, this is a criticism of mine because in the past I used to work for one of these publishers. I don't do that anymore. And the same for authors. Authors have to comply with with the best practices for systematic reviews, and being able to assure they are performed with they're performed based on reasonable, feasible approaches, and they are good from methodological, statistical, and practical perspectives. So, well, nowadays we have systematic review implemented, and when they are rooted and supported by some important stakeholders, we can assure, or at least trust, they are reliable. Nowadays, every sleep medicine society try to publish their own systematic reviews, or at least their papers based on systematic reviews, as a way of standardized clinical practice, or standardized diagnosis, or standardized patient care. So the American Academy of Sleep Medicine, for sure, is the society with the most structured and standardized systematic review procedures. They call it the clinical standards guidelines. The European Respiratory Society also has a very nice policy for that. The ESRS, our European Sleep Research Society, also have very nice systematic reviews being published. The policies are not as structured as the other ones, but the results are as important as the other ones. The World Sleep Society don't publish their own guidelines and consensuses, but they support the guidelines from other researchers, so from other societies. So if we can structure how the systematic reviews come into the evidence synthesis, we can try to summarize evidence synthesis approaches in 3 levels. Only one of them usually applies systematic reviews. So what are these levels of evidence synthesis according to the American Academy of Sleep Medicine? So I really encourage you to take a look into the practice standards website from the American Academy of Sleep Medicine. So they have 3 levels of practice standard papers: the position statements, the consensuses, and the guidelines. People most often use the term consensus and guidelines as if they were synonyms, but they are not. So the easiest of them all are the position statements. They are used when there is no evidence to be synthesized. So let's say there is some new trend being used by patients, and a society has to be very clear on saying, hey, people should not be using that. People should not be using whatever new trend that people use on Instagram. That's part of the social responsibility of society to say, hey, don't use that, or to advertise or to promote some new practice, or to alert the lawmakers about something. We have two examples here two from the American Society, one from the Canadian Thoracic Society, saying, hey, daylight saving time is not a very good best thing for under the perspective of sleep medicine. There is not necessarily evidence to be revised here, or there is no evidence, or the evidence is so evident that I can be very authoritative saying, hey, this is not acceptable anymore. And the intention here is to reach more than researchers, reach either the general public or lawmakers or the media or so on. Then we go to consensuses. What is a consensus? That's self-explanatory. Consensus is when people agree on something. And in many cases, when we try to reach consensus in sleep medicine, we are not talking about evidence. There are here 2 cases in which we can discuss about it. This is a consensus about what should be included on the clinical review of people using CPAP. So should I question people using CPAP about insomnia symptoms, or about if they sleep with someone else on their bedroom, or if they have been cleaning the filters of their CPAP machine often? There is no evidence to measure if this is necessary or not. Basically, these recommendations arise from standardized questions that are made to several experts, and if they agree above a certain threshold, this turns into a recommendation. We are working at the Sleep Revolution project on a consensus study for guiding the development and validation of new sleep technologies. So how do I suggest how a new sleep technology should be developed? I cannot measure that. I can suggest saying, hey, a randomized control trial is better than a real-world evidence study. If 75% of the experts being interviewed agree with that, then it becomes a recommendation. Curiously, in sleep medicine, there are very few consensuses being published. And this is a very hard study to be performed, even harder than the guidelines. I have recently come into a case of a consensus about the use of acupuncture to treat insomnia. I was a reviewer of a paper in this field. So basically, and this is one case in which data could be measured and a systematic review with a meta-analysis could have been performed. But rather than that, several experts on insomnia were interviewed with questions like, would you use acupuncture to treat insomnia? Which are the acupoints you would use? How do you expect that long-term effects will evolve and things like that? The result of this consensus paper was that acupuncture was the very best intervention ever for insomnia. But then you see that the consensus was applied considering that the panel board, so the people who were being interviewed, were all acupuncture specialists. So this is biased. I am asking people who do acupuncture for their lives if they trust their professional practice. So that was unreliable. We have to run away from biases whenever we perform consensuses like that. And finishing here, the third type of evidence-based approach, according to the American Academy, are the guidelines, which they standardize very nicely. I won't go through details here, but the fact that there are 4 basic steps here. The first thing is to compose your task force board. No systematic reviews with a responsibility to become a guideline can be performed by 1 or 2 people. We need a group of 20, 30, as big as possible to represent the whole field being investigated. Then we have to investigate and to develop a PICO question very precisely. A PICO question, for those who haven't ever heard of this term, PICO stands for population, intervention, control or comparator, and outcomes. Every systematic review has to have these 4 items very well defined. Otherwise, we will be mixing oranges and apples into our systematic review. Once you have our question, we might be able to go into the actual systematic review, eventually evolving into a meta-analysis. And one aspect that the American Academy considers as the most important one is evaluating the evidence, the trustability of this evidence. So one thing is to say, hey, the effect is this one. If I use this intervention, I will change the outcome this much. The second thing is how much do I trust this systematic review, and most importantly, this meta-analysis. How much it is subjected to error? What is the quality of the evidence being implemented? So nowadays, the best way to evaluate the evidence level is by the grade methodology. There are some other, there is the Oxford scales and other ones, but nothing is as precise and as complete as the grade methodology. But it's very hard to implement the grade methodology into systematic reviews. So this reinforces the need to have methodologists and systematic review experts into systematic reviews being published. So future directions into systematic reviews in sleep medicine. I do believe we have to invest in 2 things. The first one, systematic review literacy, as I mentioned before. So once sleep researchers are able to understand systematic reviews, they will be empowered to evaluate the quality of these approaches. They will be able to deal with conflicting systematic reviews, with conflicting results. They will be able to translate systematic reviews into clinical practice, and also being able to go beyond the forest plot. The forest plot is only a graphical representation of one part of the systematic review and the meta-analysis. We cannot simply take a forest plot and take it as the meta-analysis entirely. There are many things beyond that. The second one is standardization. So since the methods, the methodology, the quality of the methods are a problem, we have to have specific guides in sleep medicine telling people how to perform their systematic reviews. This is one paper I published with Ding Zhu, pulmonologist from Gothenburg in Sweden, trying to standardize the publication or the performance of systematic reviews in obstructive sleep apnea. This is one first step, and we should go way beyond than that. Regarding systematic review literacy, I will bring one example, which was discussed on here in my university some time ago. It was like a very interesting case. So someone was presenting this paper on a scientific meeting. Basically, this is a paper, a meta-analysis about hypoglossal nerve stimulation in children with Down syndrome. And you can see we don't have a proper forest plot. We have the effect sizes calculated for each individual article. And basically, we have the effect of the hypoglossal nerve stimulation into the apnea-hypopnea index. And in every case, the effect size was like large, and in most cases, it was significant. So the apnea-hypopnea index decreased in every possible study evaluating hypoglossal nerve stimulation. Is this sufficient to say that this intervention is valid for the treatment of OSA in children with Down syndrome? If I am someone who only takes the forest plot to take conclusions, yes. But if I go deeply into the data, I will see that the control groups in all these studies were not a parallel control group subjected to either placebo or to a usual care, to CPAP. They were compared to themselves in the baseline. So basically they improved, but we don't know how much they would improve if they were subject to any other concurrent treatment. Basically they improved by time, we don't know. And if we consider the adverse effects of the hypoglossal nerve stimulation, you see, and this is true for any kinds of nerve stimulation in adults, in children without Down syndrome, and so on. The amount of effect size is huge, including serious effect size like readmission, reoperation, and pressure ulcer. So the forest plots show very, very nice results. But once you realize that we don't know how effective it is in comparison to CPAP, and you realize that there are serious adverse effects being observed, is this really a valid treatment? I don't know. This meta-analysis doesn't works as a proof of effect, or at least as something that might rapidly translate into clinical practice. So when I mentioned systematic review literacy, I intend to say that people should be able to take a systematic review in hands and evaluate it critically to say if it is directly implemented into clinical practice or if there are steps to be done before it takes place. And when we go to standardization, which is basically what I have been working more and more in the last years, I really think we should have guides to tell people how to do systematic reviews in our field of sleep medicine. So one thing I have been working on is on the development of search filters specifically for systematic review, because basically this is a problem in many systematic reviews in any field. Systematic search strategies and search filters are poorly performed in many cases. In sleep medicine, it is even worse because the mesh terms that we have in PubMed and Medline, they still reflect the terminology that we used to have at the International Classification of Sleep Disorders, second edition, which also reflects DSM-4 and previous editions, in which we had the opposition of parasomnias and dysomnias, or the intrinsic and extrinsic sleep disorders. you will see there is no mesh term that is good for insomnia research. There is no insomnia mesh term. You will see that the mesh term for sleep apnea embraces hypoventilation syndrome. And we know that hypoventilation syndrome is very different than obstructive sleep apnea. So with some colleagues from Iceland, from Brazil, and from Ireland, we developed a list of search filters for sleep medicine. This is not published yet. It is under review and probably will be on a preprint very soon. We performed a list of search filters for every possible sleep disorder that is listed on the International Classification of Sleep Disorders, and some additional conditions like chronotype, like sleep deprivation, like some disorders that are not fully recognized as clinical entities nowadays, like sexsomnia, restless sleep disorder, upper airway resistance syndrome, and so on. So this shall be published soon, but if that might be helpful for any of the members of our audience here, just write me an email and I can provide you the search filters even before it is published, because my idea is to standardize it. A second thing I am working right now is on the development of specific recommendations for the performance of systematic reviews in sleep medicine, which is not an intention to replace PRISMA, because PRISMA considers the methodological aspect of the reporting of a systematic review. But I want to provide recommendations that will not be my personal opinion, but rather will arrive from a Delphi consensus study saying which should be the control group characteristics of a systematic review dealing with CPAP interventions. How should I implement inclusion and exclusion criteria regarding to CPAP adherence on these meta-analysis? Which should be the most reliable insomnia criteria for meta-analysis about hypnotics and so on? This will take a little bit longer to be available. The work is on its first and early steps, but I believe it will be very useful once available. That said, I will finish it thanking several people who work with me in systematic reviews, either using systematic reviews as research tools or promoting systematic reviews as a tool in the field of sleep medicine. So I have several colleagues here at the Federal University of São Paulo and the Sleep Institute. These three are my former advisors and colleagues. These other three are students I have who work closely with systematic reviews. I should thank people at the Sleep Revolution Group, which is a project funded by the European Union with headquarters at the Reykjavik University in Iceland. Erna Sif Arnadottir is the principal investigator. I would also like to thank some colleagues from the BRISA collaboration. BRISA collaboration stands for the Brazilian Reproducibility Initiative for Preclinical Systematic Reviews in Animal Studies. So still a tale of my previous history dealing with preclinical research, and also the funding from the AFib Association here in Brazil. Thank you very much, and I'm